All right. Welcome, everyone. My name is Catherine Freeland. I'm the Associate Director of Public Health Research at the Hepatitis B Foundation, and I am pleased today to be hosting, in collaboration with AASLD, the 2025 Hepatitis B Guidelines Key Updates and Clinical Implications webinar. We have a great panelist list of speakers today that will be talking about first the updated Hepatitis B guidelines, and then we'll be getting some clinical implications around shared decision making, and that will be followed by the patient perspective on the guidelines updates from AASLD. And these guidelines did come out late last year. So we'll be sure to share a link to the guidelines directly shortly as well in the chat. If you would like to introduce yourself today and where you're calling in from, we certainly welcome you to do that in the chat. And just note that all attendees today will be in listen-only mode, so you will be on mute. You can raise your hand if you do have questions. You can also use the chat feature to interact with other participants and speakers today. And you can also use the Q&A box if you do have questions throughout the session. You're welcome to do any of the above options for participation, and those are most welcome. Just a little bit about the Hepatitis B Foundation. We are headquartered in Doylestown, Pennsylvania, just outside of Philadelphia, but we do have offices in the Philadelphia area as well as DC. And we have a few remote employees that focus on a variety of public health programming related to hepatitis B, outreach and education, public health research, policy and advocacy, and education and training. This webinar today is a part of our continuing education efforts to make sure that folks are aware of the most recent guidelines and key updates within the field of hepatitis. And we're happy to have you all here with us today. So now at this time, I would like to hand it over to Dr. Mark Ganey, who's a senior investigator of clinical hepatology research section, liver diseases branch at NIDDK. His research focuses on improving care and treatment outcomes in patients with chronic viral hepatitis, and he was one of the leads on the updates to the guidelines. And so we're really thrilled to have him here today to share with us these key updates from AASLD. So welcome, Dr. Ganey. We're really happy to have you here.
Thank you so much, Catherine, for that very kind introduction. And it's really a pleasure to be able to present today on this important topic. So I'm presenting on behalf of the AASLD Hepatitis B Practice Guideline Panel, of which Dr. Nora Thoreau and I were the co-chairs. And actually, some of the panel members are the other panelists on this very webinar. So I think I'll just get right into it. I have nothing to disclose. So this is the guideline panel, as you can see there for yourself. And two of the panel members, Dr. Sue Wang and Dr. Jackie Chen, are the co-panelists on this. And you can see that there's a really broad representation from both AASLD, IDSA, from the pediatric space, primary care, patient representative, and then also from the Mayo Clinical Evidence-Based Practice Center. So this shows an overview of the guideline development process. So the guideline process adhered to the National Academy of Medicine standards for trustworthy practice guidelines. And the panel developed structured questions following the population intervention comparison and outcome, or PICO framework. And altogether, 75 questions were considered, of which 6 were selected for developing into complete PICO questions. The 6 PICO questions that were selected covered prevention of both vertical and horizontal transmission, surveillance for liver cancer, and treatment, including withdrawal of treatment, to provide evidence-based recommendations on these topics. The panel conducted 4 systematic reviews of the literature and utilized 2 existing systematic reviews to support the recommendations. The grade approach was used by first determining the certainty of the evidence And then to determine the strength of the evidence using a evidence to decision framework, which considers patient values, um, resource use, feasibility, acceptance, and equity. So before we actually get into what the 6 PICO questions were, I just wanted to cover how the panel interpreted strong and conditional recommendations. And a strong recommendation is made when guideline developers believe that all or almost all informed people would make the recommended choice either for or against an intervention. A conditional recommendation is made when guideline developers believe that most informed people would choose the recommended course of action, but a substantial number would not. So you'll see when I present the data on how each of the recommendations were rated, and this is the methodology that we used. Okay, so these are the 6 PICO questions, and they broadly cover areas of management related to prevention of transmission, both vertical and horizontal transmission, treatment indication in the immune tolerant and the indeterminate population, as well as treatment withdrawal, and included screening for hepatocellular carcinoma in persons after S antigen loss, and those with a co-infection, either HIV, hepatitis C, or hepatitis D. So over the next series of slides, what I'm going to cover is to give you what the actual PICO question, how it was framed, provide a rationale for why we chose that question, what was the knowledge gap that was covered, what the actual recommendation of the panel was, and then finally some key implementation points. So that's the structure I'm going to use throughout the talk. So here's the first question, and the first question addresses the prevention of vertical transmission. And specifically, it was, what is the optimal antiviral strategy for surface antigen surface antigen positive pregnant individuals with HBV DNA levels more than 200,000 IU to prevent mother-to-child transmission of hepatitis B. So the population I've defined for you, the intervention was maternal antiviral therapy with either tenofovir or tenofovir lefenamide. The comparator was tenofovir either against no antiviral therapy or against tenofovir lefenamide used during pregnancy. And the outcomes that we assessed were mother-to-child transmission, provided the infants had received standard immunoprophylaxis, and the safety of the antiviral therapy. So the rationale for choosing this is that we know that vertical transmission continues to be an important contributor of chronic infection, despite the availability of immunoprophylaxis. And immunoprophylaxis fails in 8 to 10% of infants born to mothers with a HBV DNA level greater than 10 to the 5 log 10 IU per mil. However, prophylactic antiviral therapy initiated at gestational week 28 and continued until delivery among pregnant persons with high viremia, defined as more than 200,000 IU per mil, effectively reduces this rate of mother-to-infant transmission when combined with immunoprophylaxis. So the knowledge gap that was covered with this question were 2. First, is tenofovir lefenamide safe and effective in preventing maternal to child transmission? And secondly, what is the optimal time to start and stop antivirals used for prevention of maternal to child transmission alone? So this is the recommendation for pregnant persons with DNA levels greater than 200,000 IU at any time point during pregnancy, regardless of e-antigen status. AASLD recommends initiating tenofovir disoproxil fumarate or tenofovir lefenamide at gestational week 28 to prevent mother-to-child transmission. Tenofovir disoproxil fumarate has a more extensive safety record in pregnancy compared to tenofovir lefenamide. And the strength of this recommendation was strong and the certainty of evidence was moderate. So I wanted to cover here just a couple of what I thought were the key implementation points. The optimal timing of initiation of either tenofovir or tenofovir lefenamide prophylaxis is at gestational week 28. Importantly, if hepatitis B immune globulin is unavailable, then either TDF or TAF prophylaxis should be initiated at gestational week 16. And there's one randomized control study to support this recommendation. Tenofovir and tenofovir lefenamide can be discontinued at delivery if there's no maternal indication for therapy. However, DNA and ALT levels should be monitored for withdrawal flares every 1 to 3 months for up to 6 months. And finally, breastfeeding is safe with these treatments when they're being used by the mother. Okay, turning now to PICO2, which covers the issue of whether antiviral therapy can prevent horizontal transmission. And specifically, it should antiviral therapy be provided to persons who are surface antigen positive with viremia that do not meet disease-specific treatment indications to reduce transmission in high-risk settings. So here, the indication for treatment is not to treat the underlying disease, but rather to prevent transmission and prevent from a public health perspective, prevent continued transmission in the community. And the population that's being targeted here for treatment are surface antigen positive viremic persons in high-risk settings. And we'll get to that, what those are in a moment. And the intervention was use of antiviral therapy. The comparator was no antiviral therapy. And the outcomes that we looked at were HBV infection in exposed, uninfected, surface antigen negative individuals. And then, of course, the safety of the antivirals. So the rationale for choosing this question is because I did want to emphasize that the mainstays for prevention of horizontal transmission are still HBV vaccination, use of universal precautions, harm reduction strategies, and use of barrier methods, particularly among persons who use injection drugs or are involved in high-risk sexual encounters. Excuse me. However, it is known, unknown what the level of HBV DNA suppression needs to be to prevent HBV transmission. However, it is biologically plausible that lowering viral levels to some level that hasn't yet been identified may reduce the risk of horizontal transmission. And that's why this was felt to be important and had not been covered in prior guidelines. So the knowledge gap here is, would antiviral therapy be effective in preventing horizontal transmission from a viremic surface antigen positive person without a treatment indication, but in a high-risk setting for transmission to an S antigen negative person? And this is the recommendation for persons who are surface antigen positive with viremia, not meeting disease-specific treatment indications, and who are in high-risk scenarios for transmission to others. AASLD suggests a shared decision-making approach regarding antiviral therapy. And this issue of shared decision-making, you will see appears repeatedly through the guidelines. And I think Dr. Wang is going to cover this in her talk. And the strength of the recommendation here was conditional, and the certainty of evidence very low, because there actually were really no studies in the literature that actually address this specific issue. And most of the data that we had to use to come up with the recommendation was indirect evidence. So a couple of key implementation points. HBV, I wanted to remind the audience that HBV vaccination is the primary intervention to prevent HBV transmission to susceptible individuals in all settings. So I kept mentioning throughout this PICO question persons in high-risk scenarios for horizontal transmission. So what are those high-risk scenarios? Well, persons who are engaging in unprotected sex with multiple sexual partners, persons who are injecting drugs with inconsistent harm reduction practices, persons living with susceptible household members, and finally, healthcare workers performing Society for Healthcare Epidemiology of America, or SHEA, level 3 exposure-prone procedures. This would be, for example, a HBV-infected healthcare provider performing surgical procedures. Another implementation point is one should utilize a shared decision-making approach to assess overall horizontal transmission risk and the individual's values and preferences regarding this risk, and that of taking antivirals with the primary goal of preventing transmission to others. So this is from the patient's perspective. Now, from the healthcare provider's perspective, the decision whether to recommend antiviral treatment for this indication are influenced by the individual's hepatitis B viral load, the exposure scenario, and the vaccine and immunity status of the people who are at risk for being exposed. And situations favoring antiviral treatment of the viremic person include those in which the person at risk for acquiring hepatitis B is unvaccinated, if there's been an inadequate response to vaccine, or the person has a compromised immune system, or there's unknown vaccine status. In addition, the provider should avoid stigmatizing practices and messages. And while I mentioned that we don't know what the level of hepatitis B virus has to be to prevent transmission, the goal of HBV treatment in this setting is to suppress HBV DNA to below the level of quantification. So turning to PICO question 3, this question covers the controversial issue of treating individuals in the immune tolerant phase and looks at whether starting antiviral treatment versus observation. So the patient population I just defined for you, the intervention is antiviral therapy, the comparator is monitoring or no treatment, and the outcome is hepatocellular carcinoma. And the reason for this is because there is considerable controversy whether immune tolerant patients should be treated, particularly because of the variable outcomes reported in the literature and the variable definitions used in the literature to define this phase of infection. Now, for this analysis, we defined an immune tolerant individual as someone who is e antigen positive with very high viral levels, more than 10 million IU per mil, but normal ALT levels and minimal fibrosis. Such individuals are considered at low risk for disease progression. And however, it's known that high viral levels may increase the risk of HCC, but we do know that in the immune tolerant patients, actually, that the risk of HCC is actually not linear, but rather this parabolic. So at very high levels of HBV DNA, the risk of HCC is actually fairly low. And perhaps this is something we can discuss in the QA session. So the knowledge gap here is antiviral therapy effective as chemoprevention for hepatocellular carcinoma in immune tolerant individuals? So this is the recommendation for persons in the immune tolerant phase, defined as E positive, DNA more than 10 to the 7, with normal ALT levels. The AASLD suggests antiviral therapy for those over age 40, or those with significant liver inflammation, grade 2 or higher, or significant fibrosis, defined as F2 or higher, on liver biopsy or using a non-invasive test. For persons below the age of 40 years who are interested in starting treatment earlier, the AASLD suggests shared decision-making with consideration of risk factors as well as the benefits and risks of treatment. And this sort of blends into PICO question 2, where here you're treating more not to prevent disease progression, but rather for preventing transmission to others because of the very high viral loads. And the strength of this recommendation was conditional, and the evidence was very low. So a couple of key implementation points that I wanted to review. For the purposes of assessing fibrosis, this can be done using non-invasive tests, such as hepatic transient elastography or FibroScan, or using FIB4 or APRI. For persons younger than 40 years or without significant inflammation or fibrosis, some factors to consider in guiding the decision should include the age of the person, whether a child, adolescent, or adult, personal family history of hepatocellular carcinoma, the likelihood that person is going to be adherent to treatment and monitoring and prevention of transmission to others. Close monitoring is recommended if antiviral therapy is not initiated, and HBV DNA and ALT levels should be tested every, sorry, let me just get rid of this, every 6 months for adolescents and adults, and the optimal monitoring interval for children has not yet been determined. So turning now to PICO question 4, this is also another controversial area and covers the issue of therapy for surface antigen positive E-negative individuals without cirrhosis who are in the indeterminate phase, and whether these persons would benefit from antiviral treatment. And the intervention looked at was antiviral therapy. The alternative was monitoring without treatment, and the outcome was hepatocellular carcinoma. And the rationale for this is emerging data suggests that about 40% of surface antigen positive persons cannot be classified, into one of the classical chronic hepatitis B phases. And studies suggest that somewhere between 0.1 and 3% of persons in the indeterminate phase may be at risk for disease progression and hepatocellular carcinoma. So the knowledge gap that this question covers is antiviral therapy effective at preventing the development of HCC among E-negative persons in the indeterminate phase. This is the recommendation in adults with S-positive, E-negative chronic hepatitis B infection, E-negative chronic infection without cirrhosis, and in the indeterminate phase, AASLD suggests antiviral therapy using a shared decision-making approach, and by assessing risks and benefits to reevaluate that decision at each follow-up visit if treatment has not been initiated. And the strength of this recommendation was conditional and the certainty of evidence very low. So a couple of important implementation points. Persons with advanced fibrosis, F3 or F4, are recommended for treatment. And other factors that are relevant to the decision-making, whether to recommend treatment or not for such persons, are the age and sex of that individual. And indeed, in the systematic review that was used, 3 factors were relevant in terms of assessing risk, and that was the age of the person, the gender of the sex of the person, male or female, and finally the platelet count. So for persons who were over age 40, who were male and had a platelet count below 180,000, those individuals were felt to benefit from antiviral treatment. Others could be monitored. Now, if treatment is not initiated, individuals should be monitored with ALT and DNA testing every 3 to 6 months for the first year, and then every 6 months thereafter. Now, it's important, and I want to emphasize this, that because you don't start someone in treatment does not mean that you tell them everything's fine and you don't have to come back. It's critical that this decision regarding initiation of treatment should be reassessed at each follow-up visit, as preferences and values may change over time. And individuals with persistently elevated ALT, but DNA less than 2,000, this unique group of persons in the indeterminate phase, should be evaluated for other etiologies of liver injury and managed for those etiologies if found. So some examples of this. So this would be your inactive or E-negative chronic infection group of patients who have another cause for elevated ALT. This could be underlying metabolic associated steatohepatitis, drug-induced liver injury, delta co-infection, alcohol use, etc. So turning now to PICO question 5, this question address the issue of withdrawal of antiviral therapy, and specifically, should surface antigen positive individuals without cirrhosis who have been on a nucleoside-nucleotide analog for at least 3 years and who are E-negative with undetectable DNA remain on or discontinue treatment. And the intervention was to stop antiviral treatment, and the comparator was to continue treatment. And the outcomes that this question looked at were S loss, clinical relapse, defined as a DNA more than 2,000, ALT greater than 2 times upper limb normal, and resumption of antiviral therapy. And the rationale for this is because, as this audience knows, stopping antiviral therapy is being considered as an approach to induce functional cure, that is, surface antigen loss and DNA undetectable 6 months off antiviral treatment, and to reduce long-term medication burden and costs. However, treatment cessation does carry increased risk for that individual, including virological relapse, hepatitis flares, and rarely hepatic decompensation and death. So the knowledge gap covered here is, does the benefit of stopping treatment in terms of gaining surface antigen loss outweigh the risks, which are hepatitis flares, need for retreatment, and potential hepatic decompensation and death? So this recommendation stated that in adults with E-negative chronic hepatitis B without cirrhosis and who are receiving maintenance nucleoside analog treatment, AASLD suggests not withdrawing nucleotide analog therapy until surface antigen loss. And this was a conditional recommendation with very low evidence. So a couple of key implementation points. If you are going to consider stopping antiviral treatment, all the following criteria must be met. There should be no history of advanced fibrosis or cirrhosis, decompensation, etc. If the person was E positive at the start of antiviral therapy, they should have seroconverted to E negative and anti-E positive for at least 1 year and have undetectable DNA maintained for at least 2 years. If the person is E negative at the start of antiviral therapy, the duration of HBV DNA undetectability should be 2 years. There should be no co-infection with HIV or Delta. They should have a quantitative surface antigen of less than 100 and be willing to adhere to frequent monitoring after stopping treatment. Once treatment is discontinued, serum ALT and DNA should be monitored every 1 to 3 months for the first 6 months and every 3 months thereafter for the next 6 to 12 months. Thereafter, the monitoring schedule should be at 3 to 6 month intervals, and this can be tailored depending on the ALT and DNA levels. Now, what are the criteria to immediately restart antiviral treatment? And you only need to meet one of these: a DNA level more than 10,000 IU or 4 log, independent of the ALT level, an ALT level more than 5 times upper limit of normal, regardless of the DNA, a total bilirubin greater than 2.5, or any symptoms of a hepatic decompensation. Other criteria for restarting treatment are personal desire to restart, extrahepatic complications of HBV, or they meet the criteria for starting treatment, which is shown there. So now the final question covers this issue of continued surveillance following S antigen loss or in patients with co-infection with either hepatitis C, hepatitis D, or HIV. And the intervention here is hepatocellular carcinoma surveillance versus no surveillance. And the outcome measure is early HCC diagnosis. And we know that HCC stage at presentation really is the strongest predictor of outcome. And the goal of surveillance here is early detection. And it's been shown in several studies that surveillance reduces HCC mortality and is cost-effective at an HCC prevalence rate greater than 0.2% annually. So the knowledge gap covered in this question: is surveillance beneficial in the 4 cohorts that I mentioned? And is surveillance beneficial after surface antigen loss? So I'll walk you through very quickly these, we're almost out of time here, these recommendations. So for persons who achieve surface antigen seroclearance, AASLD suggests continued surveillance for those with cirrhosis, with a family history of HCC, men who cleared surface antigen after age 40, and women who cleared surface antigen after age 50. And the strength of the recommendation is conditional, and the certainty of evidence very low. So what about persons with HBV, HDV co-infection? AASLD suggests HCC surveillance of adults independent of cirrhosis status, and the decision to undertake surveillance in children should be individualized due to the risk of HCC being unknown in this population. And similar to the previous recommendation, the strength was conditional and the certainty of evidence very low. What about those with HBV, HIV co-infection? AASLD suggests HCC surveillance for adult males or persons greater than or equal 40 years of age. Same strength of recommendation, same certainty of evidence. And finally, for persons with HBV, HCV co-infection, AASLD recommends treatment for hepatitis C with DAAs and suggests HCC surveillance as per criteria for HBV monoinfection once HCV clearance has been obtained or achieved. And the same strength of recommendation, conditional, certainty of evidence, very low. So finally, a couple of key implementation points. The recommended surveillance is ultrasound and serum alpha-fetoprotein levels performed at roughly 6 monthly intervals, as recommended per the 2023 AASLD HCC guidance document. And then for those persons for whom timing of surface antigen loss is unknown, and this often happens because we don't follow these patients as closely, the decision to undertake surveillance should be individualized with consideration of presence of underlying cirrhosis and family history of hepatocellular carcinoma. For those persons with prior Hep C and hepatitis D co-infection, surveillance for HCC is the same as those with HBV alone. And finally, for persons with triple or quadruple viral infections, surveillance recommendation should be that of the co-infection associated with the highest risk of HCC. So one question is, what will be the potential impact of these new HBV guidelines? And obviously, since they've only recently been released, we don't know. But what we hope is that it will lead to reduced rates of vertical and horizontal transmission. And we do hope that it's going to lead to expanded access to treatment. And I'd like to highlight that the panel carefully crafted the recommendations to make them more permissive and less restrictive. And there was this focus on shared decision making, which Dr. Wang is going to cover in her talk in just a few moments. So I think the guidelines really now does allow almost all patients to be treated if they do wish to be treated. And finally, to broaden the population who may benefit from screening with early HCC detection. So I would like to end here by just acknowledging many people who helped with developing these HBV guidelines, in particular the writing panel, the Mayo Clinical Evidence-Based Practice Center, the AASLD Practice Guideline Committee, and the AASLD Practice Guideline Resource staff, our IDSA colleagues, and most importantly, our patients, for whom we hope these guidelines will lead to improved outcomes and a more healthy life. So thank you so much, and happy to take any questions now or after all the talks. So thank you so much for your attention.
Thank you so much, Dr. Guinea. That was an excellent overview of the slides. And as Dr. Wang is coming in with her presentation, I might just ask one quick question before we jump into Dr. Wang's presentation. But you mentioned a lot about surveillance within the guidelines. One question that I always am thinking about is, how do we keep patients coming back who might not be indicated for treatment, making sure that they're maintaining that surveillance? I don't know if you have any tips or suggestions from your practice that you might be able to share.
Yeah, Catherine, thanks for the question. So the question that Catherine was asking is, what tips could we recommend to keep patients engaged in HCC screening programs? And actually, what we do at our center is patient education. So we make sure we tell patients that hepatitis B is a chronic viral infection that increases your risk for liver cancer more than 100-fold that of persons who do not have HBV infection. So I think just by educating them and letting them know that they're at risk, that helps. But that alone obviously is not enough. This is where I think the electronic medical record can really help you, because you can put reminders in the patient's chart for upcoming visits to remind yourself and the patient that they're scheduled for HCC surveillance. And what I do in my practice is I schedule the ultrasound surveillance and alpha-fetoprotein level at the visit that I see the patient. So it's already, all the orders are already put in. And then finally, we also send the patients a reminder that they need to come in. Now, I know that might be challenging for busy practices, but those are some of the strategies that we use to keep patients engaged. But the key really, I think, is education, because once persons understand that they're at risk, they're more likely to engage in continued surveillance.
Great, thank you. Thank you so much. And we do have some questions coming in, and we're going to get to those as a collective group. But now I'd like to turn it over to Dr. Wang, who will be talking about patient-centered care and shared decision-making within the context of hepatitis B. Dr. Wang's the medical director for the viral hepatitis programs and Center for Asian Health at Cooperman-Bartemus Medical Center in New Jersey. And she's the past president of the World Hepatitis and Alliance and senior advisor for global health at the Hepatitis B Foundation. And Dr. Wang, your slides, I think, need to be switched screen. It's showing like presentation mode as well.
Oh, I do that. Okay, so let me end show.
If you just, yeah.
What do I do? This button?
Where's your mouse?
Oh, here.
Yeah,
oh, wait.
Yeah. There you
Yeah,
go.
this. I have this. That's what I did before that.
Should work. Hopefully.
Hold on, let me see. The other thing I could do is literally just go into like the
go to your display
because
setting.
you're basically yeah.
Yeah, and then I think you should just swap.
Okay, thank you. Learned something today. All right, thank you guys. I'm excited to talk about shared decision making because I think it's a really key thing about the new AASLD guidelines, and we want to just do a spotlight on those. So. First off, just take a step back in terms of like thinking about our understanding of Hep B really being incomplete without also assessing the patient's experience, or what we're hearing more talked about is patient-reported outcomes. Institute of Medicine reports describes this as any report of the status of a patient's health condition that comes directly from a patient without interpretation of the patient's response by a clinician or anybody else. So this is capturing really the lived experience with the condition and its impact on the many aspects of a person's life. And so rather than, we don't want to just focus just on the liver, we want to assess the whole person impact of hepatitis B. And usually we often are really focused on like just the clinical endpoints, like the labs, imaging, and not always taking into account Hep B's impact on one's daily life. So there are more and more studies now finding that Hep B is not a silent disease. One aspect, even clinically, that sometimes there's inflammation in the liver even when the lab tests are normal. So we look at liver enzymes, we look at our fibrosis scores, but we know sometimes when we look at the actual biopsies of liver, sometimes we actually do see some fibrosis, even though our lab test didn't always show it. So that's why it's so important to do the ongoing care, because if you only come, once a year or every other year, you're going to miss that sometimes. And then also experientially, patients may have symptoms even though they don't have lab evidence of liver inflammation. And we're learning that it affects multiple dimensions. So not just physical, where you might see fatigue, but also psychosocial, where there's a lot of worry and stress, and maybe some stigma, which can be what people feel from outside stigma, what other people think of them, but also self-stigma, that people feel like they're infectious and they have this disease, and that affects how they see themselves. This was an interesting survey that was done actually for the WHO guidelines, which came out in 2024. This was done by the Hep B Foundation. Catherine was involved with it. And it was basically looking at this part of the survey, and this was global. There were 500 people who participated, looking at patient-provider communication. I think this evidence really showed us like how important shared decision-making is. So when we asked the patients, did any of your healthcare providers explain that there were choices in what you could do to treat Hep B? It was surprising that like 48% said no, that their doctors didn't get to talk about options. And then when asked, did any of your healthcare providers ask if you wanted to start treatment? Similarly, about half said no. And then lastly, do you want your healthcare providers to ask you to be more involved in choices around your Hep B management and treatment? Or sorry, the word more is not in there, but to be involved. And 85% said yes. So obviously, I think patients do want to be involved with their care. And maybe this was very self-reflective to me as a physician that, hey, I think I'm telling patients everything, but patients often are not hearing or don't always get told all the options they have. So what is shared decision making? I think sometimes it comes off as kind of the soft term in medicine. And maybe like it means like we don't know what it's not a strong recommendation. It may seem that way, but I think what's really important is that especially in decisions that may be equal. You may have two equal options, that it's even more important at that point to have a collaborative process between the clinicians and the patients. And so you see this Venn diagram where you're looking at the provider clinical judgment and their experience, and then the patient's preferences and values, and then also the evidence-based medicine that we have. There may be cost and access issues or other circumstances. And the meeting of all three of those is shared decision-making. So to do true shared decision-making supports person-centered and equitable care. Research shows that it increases patient engagement and it improves both the patient and the clinician experience. So one of the slides that I took out for time sake basically had three recommendations, and one of them was like a physician saying, oh, based on your lab results, I recommend this. And that sounds like pretty standard, but that sometimes leaves out the patient input, where it might be phrased as, you know, based on your labs, I recommend this, but I want to hear what's important to you first. Or based on what you've told me and based on your labs, this is what I recommend. So there are different ways of where we might change how we do things to make sure we incorporate the patient's input for more. So this is an HRQ or ARC shares a shared decision-making training that they have online, easy to find, got lots of great resources. But I love these steps. So step one is first, seek your patient's participation. So communicate that there is a choice that exists and encourage your patient to become involved in the conversation. And this is really important. Otherwise, patients don't realize we're inviting them to participate. Step two is to help your patient explore and compare the treatment options. So lay it out, discuss the benefits and risks of each option. And then step three, then you want to assess your patient's values and preferences. Take into account what matters most to the patient. So for some patients, they may say, you know, I really want to do something about my Hep B. I'm so worried, you know, about getting cancer, and, you know, they want to be proactive. And you might have another patient say, I don't want to be on medicine no matter what, unless I absolutely have to, right? So you've got patients with different values and preferences. Step four is to take that into account along with the labs and reach a decision with your patient and decide together on the best option. And step five, evaluate your patient's decision. Is it reasonable? Are there any concerns based on the decision? All right, so what's exciting this year is that we had two guidelines come out that incorporated shared decision making. So before AASLD came out, the EASL, the European guidelines, came out in spring of last year, and they also bring up SDM. So they are statement, which I loved, and Mark kind of affirmed this too, that we are making it so expansive that there's no Hep B patient who, if they wanted to be on treatment, we would say, no, you absolutely cannot be on it. So here the statement is, in principle, all Hep B surface antigen positive individuals with detectable DNA are candidates for therapy. The indication for treatment is primarily based on Hep B DNA and ALT, fibrosis stage, and risk of liver progression. So very similar to AASLD. And then they have a whole paragraph on SDM, which I'm not going to read about, but just is great to see this front and center in the European guidelines too. And then Mark talked about the Hep B ones, and then just want to highlight that like there are three specific indications where shared decision making comes into play, and he went over these thoroughly. So the horizontal transmission, the indeterminate phase, and then the immune tolerant phase. So how do we do this? And this is something my practice is piloting, coming up with a shared decision making tool. So we're calling this Be Smart, and basically we want to assess patients' PRO. So what is the impact of Hep B on their lives? And so we ask them, how are you feeling? You know, do you have symptoms? Do you not? How much does it affect your life, Hep B? And then what are your biggest concerns? Is giving it to friends or family who aren't immune? Is developing liver cancer? Is it being on lifelong medication or side effects? Or is it being treated differently or stigma? Or are you not concerned at all? And this helps you understand, you know, how much, you know, what are the things that bother your patients? And then also like ranking what are the concerns they have, because this is helpful. And this was actually based on a PCORI grant for Hep C, where they did something similar, kind of looking at what's the most important thing people are concerned about with Hep B. I mean, they did it for Hep C, and we're doing this for Hep B. And then we take the labs, put it into a table, go over it with the patient so they understand if they're in they have low viral load or high viral load or their ALT or how their fibrosis score is. And that way kind of simplifies kind of what the category we feel like they are in based on their labs. And then finally, we go through the decision-making process. Are you interested in starting medication? If you are recommended to start, but you're maybe not interested, what are your concerns? And if you are recommended to start medications, how confident are you that you can be compliant with the medicine? And then there was a decision making that's being done, which says after our discussion today, we decided to either start treatment, continue monitoring, or still deciding, or we'll revisit, or if they're already on medication, they continue. So, and then we go through which medications and talk about follow-up. So this is piloting. Hopefully we'll release it soon. So, and then finally, I just want to say, I know there are a bunch of people here who are like on the public health side, that a number of us who are actually involved with the AASLD guidelines also then went on to work on this guidance for a primary care provider to kind of simplify things a little bit and also create some really good resources for people who are not as familiar with Hep B as maybe the specialists. And so you can find this on this link here. It's housed at University of Washington's website, but it's on a mobile version and also PDF. And then there's a one cheat sheet, which I think is great, even with like screening tables, so you know how to interpret the screening tests, vaccination recommendations, and some of what we just talked about. So it's not the AASLD guidelines, but it's a spinoff based on some of the work that we did there. So I will just close there. Thank you. And back to you.
Great. Thank you so much, Sue. And I put the link to the primary care guidelines in the chat as well. Now I'd like to pass it over to Jackie Chen, who's the professor, Dr. Stephen Harrison Patient Advocacy Fellow. He's in Princeton, New Jersey. He's also lead of the Taiwanese Hepatitis Information and Care Association, FICA organization, and he'll be discussing clinical decision guides in chronic hepatitis B and the lived experience. So Jackie, over to you.
All right. Thank you very much, Catherine. Can you see the share screen okay? All right. So
Yes.
thanks, Catherine, for the kind introduction. It's truly my honor and pleasure to be here. I will be sharing my perspective regarding the AASLD guidelines, specifically from a patient's point of view. As someone who isn't a provider, I'm not a doctor, I'm not seeing patient, it is really a rare and vital opportunity to participate in a meeting like this one. And I also deeply appreciate the opportunity provided by AASLD for me to participate in the guideline development process, and to the Hep B Foundation for giving me this platform to share my lived experience. Now, after listening to Mark and Sue's expert presentation, I'd like to dive into where this guideline might meet the reality of the patient journey. I will share a few slides, and these are initially generated by AI for simplicity and clarity. However, when we go through them, you will notice some highlight and error, and this represents my personal deviated viewpoint, area where I think the patient community feels the guideline could push even further. My hope is that by highlighting this gap, we can spark the kind of discussion that shapes the next generation of the guideline. So you can see from this slide that the guideline, as Mark has mentioned, that it involved in many processes, including the development of the PICO question, the systemic review, the GRADE approach. All those are not. I wasn't involved in any of those. I was only involved in the latest guideline discussion, and also at the second half or the later stage of the guideline discussion, which means that they have already mostly discussed already, so they invited me later in the process. So I wasn't aware of any of this. And however, as you can see that this earlier part of the process actually provide a very important framework for what the guideline can be. And actually, it kind of dictates what the guideline can say, because you want it to be a evidence-based. So basically, this, when there's a great approach, then they have already decided what you can recommend and what you cannot recommend. So unfortunately, there are not much deviation or not much things that we can discuss at the guideline development, the discussion process. But just a few points I want to point out, including the first one is the postpartum management for prevention of vertical transmission. You can see that the point I want to point out here with this arrow is that they will recommend and continue to recommend discontinuation of treatment after, even at delivery or soon after delivery. This is something that I think is at risk for patient, for the mother, and also for the infant. And I try to, provide some perspective on that. But I think this is some area that it can improve. If the mother is in good condition when they are on treatment and there's no risk for them to take the medication, why to discontinue them? And we have seen so many patients, not many, but a few, and they also come out to present their story when they were told to discontinue their medication after delivery. Then they flare up, they got acute exacerbation, and actually one patient get into liver cirrhosis at the age of 30, and this is not really, I think there's a high risk here that if we are recommending the mother to discontinue the medication after delivery. The second part is the immune tolerant phase. And this is one part that I try to raise concern, which is the age that, we sort of come to a compromise that we will suggest treatment at some sort, but there's a cutoff when to start the suggestion. And eventually it was settled at age 40. And I was not happy with that age number because, at that time, WHO, ESO, and other guidelines have already said 30, not 40. So I tried to convince the group that we should change it to 40. Unfortunately, I couldn't succeed. But anyway, this is something that is a gap that I think the AASLD need to reconsider, that we should lower the age to recommend or to suggest treatment. And by expanding that, because we are not treating the patient, we are doing the prevention. We don't want them to develop a problem, at the age 40 and you continue treatment, you want to prevent that from happening. And we have seen so many patients who come out to tell their story in their age 30, between age 30 and 40, because they have already have acute exacerbation induced even for liver failure. So I think this is very important that we need to consider to push this age limit to a lower age to start treatment. And this is a complex patient, and basically this is the patient in the gray zone. In the gray zone, which means that they have a very low viral load but a little bit higher ALT, and also a patient with a gray zone with everything is normal, but they have the other condition, diabetes, obesity, or kidney disease, or anything. And my point is here is that there's a progress in this part is that the guideline change from not recommending treatment to consider treatment, which is a great breakthrough for me. I think it's a good news for the patient in the gray zone. And another point is that when they have comorbidity, I think why you want to try to treat those that are not easy to treat, and then forget about the Hep B part, which is very easy to suppress. You don't want to patient to be, have to worry about multiple conditions. If they can get rid of a Hep B virus, then do that first. And then you take care of the obesity, take care of diabetes, take care of a kidney disease, that you don't have to complicate the patient's situation. So this is something that I always try to talk to the provider, the physician, that you need to treat Hep B first before you trying to think about other conditions. And this is also the gray zone phase. And I think one thing that I like and I highlighted here is the shared decision making. At least they give the patient the opportunity to say that, yes, I want to be treated. And as long as you ask, I think the doctor would be able to listen to you now, because they are instructed to do a shared decision making, right? And this is the one part that I like it, that I didn't have much comment. This is by a senior expert in the writing group. And the reason I like it is that first, the outcome of the first recommendation is that you don't stop, okay, until there's until you are cured, functional cure or whatever. But if you want to stop, then you have to fit all 5 conditions. So all of them, that's good. That's good. If it's 20%, 20%, 20% times 5 times 20%, then the number that would fit into this is very, very small. So I think this is okay. Not many people would be able to qualify for discontinuation. Then that's good. I think the patient are in safe hand. So this is I'm fine with it as long as they can continue to frequent monitoring if they stop the medication, and then to remain safe. All right, so but I know that the time is up, and I want to make it very brief. And this is the final slide that to pinpoint all the pickle question, the 6 question, and just summarize what I have here. Pregnancy, I would say you have to continue at the delivery. Just don't just ask them, blanketly that you can stop. And then for the transmission, I don't like the term high risk. What is high risk? I would say if the patient feel that they are at risk, then you should offer treatment. I feel that I'm at risk of transmitting the virus to my whoever that I don't want it to be transmitted. And the immune tolerant phase, again, lower the age to 30 at least at this point. For the gray zone, I would treat all the gray zone patients. Don't just say, you can consider treatment, but all the gray zone patients should be offered treatment. And if they don't want it, then they have to be closely monitored. For the withdrawal, don't stop until there's a surface antigen loss. And then for surveillance, I do not have any additional comment. So those are what I want to say, and I really appreciate the opportunity to be able to share my perspective. And so with that, thank you for listening to this perspective from with an open mind, and I hope this point can serve as a bridge for our upcoming discussion and how we can continue to refine the care for the million of people living with HBV. So back to you, Catherine.
Thank you so much, Jackie. You raised a lot of really important points that have been topics of controversy, I think, in many of the hepatitis B decision-making discussions that we've had. So I really appreciate you bringing all of those up and providing the patient perspective. We did have a couple of questions come through. I know we're a little short on time, but I wanted to at least get to a couple of them if we can. The first question regarding transmission, was there any discussion about treatment as prevention as a recommendation within facilities as an indication for shared decision-making? And this person specifically is thinking about carceral facilities and the impact that could have. I don't know if Dr. Gainey had any thoughts on that, or if that was part of any discussion in the guideline development.
Yeah, so if I got the question correctly, Catherine, you were asking about if we specifically recommend treatment as prevention in certain high-risk situations, such as incarceration.
Exactly.
I think the guideline sort of stays away from making, sort of specific recommendations in different populations. I think, as Jackie was highlighting in his talk, and I did with recommendation number 2, was any situation in which there may be a risk for high-risk exposure. That's a situation in which one can consider starting antiviral therapy with the sole purpose to prevent transmission to others. But I would highlight and like to reemphasize the point that even though we offer that recommendation, the mainstay to preventing transmission is vaccinating the at-risk individual. So I think we should not forget that part of the recommendation either, that we should continue to recommend vaccination and catch-up vaccination for those who may have missed it. And the CDC also recommends that as well, catch-up vaccination for those who may have been born prior to 1991 when the recommendation first came out. But yes, high-risk individuals can be considered to receive antiviral therapy to prevent transmission to others. But we don't have specific recommendations that say in certain high-risk settings such as incarceration in your example, that's left on an individual basis. We don't make sort of blanket recommendations. And it's important there to consider the shared decision-making process. And maybe Sue might want to comment there, because really, we're treating the individual not to prevent harm to themselves, but really harm to others. And that's where I think the shared decision making becomes relevant and important.
Yeah, I think the recommendations are a start to doing more in this area, because like you had mentioned, it hasn't been incorporated in any guidelines, this concept of horizontal treatment. And so I think, we should be exploring kind of where these scenarios are. So it'd be great to kind of look into more of this, as we move forward in terms of we need specific kind of recommendations for different settings. Back to you, Catherine.
Yeah, thank you. Also, we do have public health prevention tools within hepatitis B, as Dr. Gainey mentioned, with vaccination. So I think that's an excellent tool as well, to make sure that we're implementing effectively. The other question that we received, what is the problem if we treat all positive patients? So kind of in a similar alignment there. I don't know if anyone has any thoughts on wanting to take that question, or if you have a perspective, but that I think is a very controversial topic in the space that we have now.
Do you want me to have a stab at it? I mean,
Sure, feel free.
Go for it, Larry.
It's not an easy one.
It is a controversial question for many reasons, right? I will say that that approach has been sort of been considered, and it's been adopted actually in the Chinese guidelines, that basically anybody over age 30 who is viremic can be considered for treatment. Now, China is considered a sort of, well, it used to be considered a high endemic area. Now it's sort of a more intermediate endemic, low to intermediate endemic, because they've done such a great job with vaccinating their population. But still, a significant proportion of the population is at risk for complications of the disease because they've had it, I think, for the majority of them, since birth. So there's that factor to consider. I guess here in the US, hepatitis B is the demographics of hepatitis B are a little different. And certainly there's also, I think, good evidence to show that with careful monitoring and instituting treatment when it becomes necessary based on guideline recommendations, that the outcome is exactly the same. So I think either approach could be feasible. Obviously, treating everybody carries increased cost, also carries increased need for monitoring as well. People think that when you start treatment, it means that you don't need to monitor the patient. That's obviously not true. You still need to monitor the patients to make sure that their adherence and that no complications, albeit the risk is low. But you can get exactly the same results by close monitoring and starting treatment. And that data came out of the Hepatitis B Research Network, where patients were closely monitored every 3 to 6 months. And when they met a treatment indication, they were quickly put on treatment, and we had very low rates of outcomes. So I think if we get to the point where we have finite treatment that's effective at clearing S, I think we will probably make that transition to recommending treating everyone. But here, where it's suppressive maintenance treatment, I think that's why there's still controversy. And I mean, I understand both sides of the argument. It's just that the evidence at the moment, we don't have the evidence yet to kind of recommend blanket treatment of everybody. That's sort of lacking. But I think, I mean, we had this very same discussions with hepatitis C, if you remember, right? Who to treat and who not to treat. And then once we had direct acting antivirals available, then we just basically changed the recommendation to everybody should receive treatment. I
Yeah,
don't know if Sue or Jackie has other ways to to look at this, but that's sort of
yeah.
my perspective.
I'm gonna just real quick, I think what the person's referring to is this like concept of treat all, right? Which is what we see in HIV and Hep C. And I think I agree we're not quite there with Hep B, but we definitely need to treat more. And my personal belief is we should offer everybody the option for treatment. I don't know that not everybody's scenarios are different, right? If you're not viremic, you have low viral load, but if you're not going to be compliant, right? But I think everybody should have the option to have that decision. And a lot of times we have not even offered bit people until they, had, really late stage inflammation or abnormal. And so I think that's where I'm hoping the guidelines change a little, where we talk about the option much, much sooner. Jackie, what are your thoughts?
Yeah. So yeah, yes, of course. Thank you very much for giving me the opportunity to share. So I would say that let me put it this way. I, I think the question, just to answer the question, why not treat? What's the problem of not treating everyone? And I think the only problem now is that can you provide everyone the medication, the cost for it to cover, right? So if it's free for everyone, if there's a budget for it, and it's you don't need to worry about it, and but I think that shouldn't be a problem of a medical recommendation, because that is a problem of the government, right? Whether they want to provide a free medication to everyone, or the insurance will cover everyone's, so that is not our problem. That is not a medical recommendation need to consider at this. I would think that is not what we need to consider. So the only thing that we need to consider is that is there any detrimental effect to the patient who are taking it for long term? Is there side effect? Are there associated, bone problem or kidney problem or any other risk that could be raised because of a long-term treatment, right? And I don't see evidence for that right now. I think the evidence is very low. All the medication are very safe for long-term use. So I don't see much reason at all for not offering treatment. And I'm against of not offering it because that you are all saying that there's no evidence of supporting the benefit of early treatment or treat all. But I would say that it does. Why? You get rid of the virus, and we know that if you get rid of the virus when they were first born by giving them the vaccine, then they lower their risk of childhood liver cancer, right? That has been proved. We have evidence for that. Not only that, we have evidence for treating early, a great zone. We have talked about that agree on a 30% reduction, although we emphasize that there are 60 to 70% reduction in the liver cancer rate. So we have that. And we have seen so many patients that are in their young age, I'm talking about 20, 30, that they develop liver cancer, that they deliver liver failure because of acute exacerbation. And we've seen that every day, that is still coming out. And all those can be prevented by treating them early. So when you are saying that there's no evidence of or no a benefit of treating them early or treat them all, I think we have if you're talking to different person, they would have said that we have plenty of evidence for that. At least you can suppress the virus. Even though not undetectable, it could reduce million for even higher rate, right? And that would reduce or cut the risk to substantially. So I would argue against that there's lack of evidence for that. I would argue the only thing to argue is that obviously, whether is really cost benefit, whether there's such an effect that we still need to analyze. But I think there are also some report on that. There's cost benefit on that as well. So I think the society need to look into it more carefully, more closely, not giving us a graded recommendation, a systemic review saying that we have to follow what the evidence say. We are the person who judge the existing evidence. I think the physician or the provider or the society have to do that. I've talked to several people, including the infectious disease president, other people, and talking about this guideline. And some of them, when they are in a position, they could be just like conservative. They don't want to say anything negative about it. But there are people who would just say outright that this is not right. I don't like it. I don't like it. So I, I'm just hoping that in the next step that we can move forward. I think it is going to move forward to that direction anyway, sooner or later. All right. And obviously, if there's a good medication come out, it will move the pace much faster.
Mm.
Thank you.
So if I may just make
Sure.
one comment. So I don't disagree with you, Jackie. But I will say just so that the audience knows, there's no evidence actually to show that treating a highly viremic person will reduce their risk of liver cancer. That data doesn't exist, which is why we can't make that recommendation, right? I mean, we should at least be fair to the data. And not say it's that, not say that we want to be conservative and don't want to make this recommendation. But that said, I think there's also, currently there are people who it's difficult to show that treatment will actually lead to a benefit and reduced outcomes, right? Just because it takes so long for these complications to develop. And I get Jackie's point. If I were a patient and you think that you think that no virus equals no disease, then yes, that makes sense. And for a disease like HIV, for example, clearly reducing viremia is associated with reduced risk of complications and development of advanced HIV disease. But in hepatitis B, for example, it follows a different set of pattern set of rules, right? As we see that the DNA level is not directly related to outcomes. It's this parabolic shape. So at the very extremes, the risk of complications is very low. So you actually have to treat a huge number of patients to get a benefit. So we can think about it in terms of public health benefits, in terms of individual benefits, and you can come up with different reasons, right, on whether to recommend a treat all or a individualized approach, right? And we are where we are at the moment. I think just I would agree completely with Jackie that once we have better treatment, all these discussions are going to go away, and we will recommend treating everybody. I just don't think we're there yet.
Thank you. Yeah, I think this conversation really highlights the controversial conversations that are continuously going on in the hepatitis space. I wondered, Dr. Wang, I know we're over time, but do you have any last comments on this point? Because I do know it's a hot topic in the space.
No, this is great. And I think looking at the audience we have here, a lot of people are kind of on the front line. So I think, the message is, we've got great tools to expand care. Hep B should be something that we want frontline providers to be able to at least start the process, start the screening, do initial testing, with the whole host of guidelines. We have all sorts of guidelines, WHO, EASL, HEP, the primary care ones, and AASLD. If we almost took a best of, I think anybody could kind of do something to help provide more care. We don't want it just to be like, the tertiary specialists who only can provide care, but we've got some great tools now. So, I'm proud of where we are. We definitely have a lot of room to go, but this is a great session to kind of go over that. Thanks, Catherine.
Thank you.
Just to end on a positive note here, Catherine. I wanted to reemphasize what Sue said, that the guidelines are clearly more permissive now. Okay, and almost everybody can be treated if they have this shared decision-making conversation with their doctor. I think you can find a recommendation that allows you to receive treatment. So we're not trying to prohibit or block anybody from receiving treatment. And if anything, we've made it a lot more permissive. So I think that's a step in the right direction.
Definitely agree. We've come a long way, I think, in just the past 10 years that I've been working in this space. So I think we have a long way to go, certainly. We still have a lot of people to test and link to care and treatment. and making sure they're getting surveillance as well. But I think we're making positive forward progress. So I want to take a moment to thank the audience for being with us and for staying a little bit over time with us today. Really appreciate your engagement. Also want to take a moment to thank all of the speakers for their excellent and really insightful thoughts and discussions today. As you can see, this is a really emerging conversation that will continue. We hope that you'll help us disseminate the guidelines broadly and share them widely with your networks. We know that it takes a while to get guidelines into practice, and that's something that we're really prioritizing. We will be sharing a recording of today's webinar along with the links that were discussed for the guidelines themselves, both the WHO ones, which I think were mentioned, the primary care guidelines, and the AASLD ones. So please feel free to share. If you have any follow-up questions or concerns, please always feel free to reach out to the foundation. We're happy to link you with any of the speakers as well, if you're interested in connecting. But wanted to take a moment and thank again the speakers for being with us today. And thank you all as participants. I really appreciate everyone's time and look forward to the next steps in the hepatitis B space as we move into the future. So thanks, everybody.
Thank you.
Thank you.
Thanks, everyone.